Okay.
Here we go. Are you ready?
I'm ready. You ready?
I'm ready. Hi, everybody. This is Cindy Kennedy, and you're listening to another episode of Living with Lyme. And today we are going to talk all about SIBO. And our guest is Dr. Thalia Farshchian, and she is a naturopathic physician at Medical Options for Wellness, and she's in Foster City, California. And she came across a big need with gut disorders, and as everything happens, one thing leads to another, and now she has a passion for treating Lyme disease, co-infection, mold toxicity, inflammatory disorders, as well as mast cell activation syndrome. She and I met because of a flash drive, and that is so cool because I just showed her before we started recording. Do you remember this? This is how we met. It's so cool. So she really understands Lyme and the constellation of symptoms that go along with chronic illness. So Dr. Thalia, nice to meet you again and have you on the show.
Thank you so much for having me, Cindy.
You know, you've been a wonderful mentor to me with SIBO because I've had a couple of people, and because I was kind of leaning towards, okay, which pathway do I go? You were extremely important to me because you really helped me help this person. And with your experience, I thought maybe we could get a good discussion going about SIBO. So SIBO, give me what it is.
Mm-hmm. So it stands for small intestinal bacterial overgrowth. So oftentimes people are like, what is that? It's one of the main causes of IBS. And basically what it is that it's actually an overgrowth of very normal bacteria. A lot of times when things go wrong, we think it's bad, it's not good, it's something we have to combat. But it's actually just a displacement of good bacteria into a place that shouldn't have that type of bacteria in it. And a lot of times when I'm going through this with patients, I start drawing the anatomy because it helps it to actually sink in as to what it is. So when we look at digestive anatomy, it actually starts in your mouth when your enzymes in your mouth start to break down your food. And that gets triggered by the brain because you smelled food, you saw food, and your brain starts triggering like, okay, let's get these juices flowing. And then when it drops down the esophagus, it meets the stomach where hydrochloric acid chimes in and starts breaking down food. And then it goes into the small intestines. And what happens with SIBO is we get these symptoms of abdominal bloating, abdominal pain, a lot of upper GI stuff going on. And that's really because the small intestines is by no means small. It's 20 feet long, but it's only an inch in diameter. So when you have abnormal bacteria in there creating gas, which they naturally do, you have this small amount of space that starts pressing on, and it's that nervous system that causes that feeling of pain. So the upper GI is really important, and that's where the small intestines, you know, a lot of people think of it being quote unquote small. It's actually very long, and it has a huge function in the digestion, the breakdown, the assimilation of our food and our nutrients. Which is why, you know, when people have an issue with the small intestines, we see such a wide variety of symptoms actually coming through.
So going past the small intestine, we go to the large intestine, but that's not as large as we think, right?
No, it's 5 feet long. So it's really not as large. It's 3 inches in diameter. So obviously that's a bit more than the small intestines. But then when the bacteria creates gas in there, it's not really a big deal because we have the space in there and it doesn't cause that same tightness that we feel in the small intestines. And there's obviously a lot of important junctures along that way. I obviously skipped a few steps, but there's the lower esophageal sphincter, you know, there's the pyloric sphincter, there's the ileocecal valve. So we have a lot of stopgaps along the way to help our body, you know, really take it step by step and move our food forward.
So, you know, when hydrochloric acid is produced in the stomach to start breaking things down, does that now stimulate pancreatic enzymes for further breakdown?
Yeah, we see they obviously work in concert, and we get the hydrochloric acid coming in from the stomach. And then simplistically from the pancreas, we're getting a lot of the pancreatic enzymes. And then also small intestines, we get this meeting of the bile as well to help break down the fat. And so all of these pieces actually prevent bacteria from growing in the wrong places. So if we have any dysfunctions from a physiologic component in those arenas, that creates a situation where SIBO could really flourish and become a thing.
We know about gallbladders being a pouch and that holds your bile, and it kind of waits there to be released. So when people have ultrasounds to see if there's something going on with their gallbladder, you know, you can't eat or drink because you want to see it full. What happens when people have a gallbladder that's bad and they have a gallbladder removal? Where is the bile stored anywhere else?
I mean, really the bile comes from that area. So when we get people who've had a gallbladder removed, they don't have that any longer. And I remember starkly in anatomy, when we would look into a body that had a gallbladder removed, there'd be a big green spot where it was left behind, because obviously that's the color of bile. And so, you know, I really think it's unfortunate, but so many patients who have their gallbladders removed aren't appropriately managed post-surgical care to be given the supplementation that they will require for the rest of their lives to break down the fat and break down the nutrients that they need. Simply taking something like that out can actually predispose people to SIBO and make it an issue. Just adhesions aside, the scar tissue aside, you know, not having that powerful support really causes an issue down the line for them. And it's not uncommon that a lot of my SIBO patients have had their gallbladders removed. And it's really chicken or the egg there.
You know what? I don't think, you know, people who are not medically inclined or, you know, have any background in this don't understand what we mean by breaking down the food. I think that is something that I'd love for you to explain in simple terms. It's not as so much as making it smaller pieces, is it?
Not exactly. I mean, definitely breaking down the food, we're trying to break it down into the nutrients and really grab at that. And that obviously takes a lot of different moving parts. You know, eating is a very energetic process. It requires a lot of energy to break down food. Our stomach takes a long time to do it. And that's why, you know, oftentimes with SIBO patients, we're asking them not to eat many meals throughout the day, because your system is constantly trying to break down those little bits of food when the nervous system really likes for food to get in, it to work on it and break it down with the appropriate enzymes, bile, hydrochloric acid, all that stuff gets in there. And then do a sweep where the nervous system basically sweeps this food out of the small intestines and into the large intestines. So when you're snacking a lot and eating mini meals, you know, food's going in, it's like digest. And then it's that stopping point that makes the nervous system push it forward. So if you keep snacking, it's like digest. Okay, digest, you know, and it keeps doing it, and it never does that clean sweep that it needs.
Right.
And that's the migrating motor complex that they talk about, which does that sweep for us.
Right. And, you know, the old way of saying, you know, you've got to eat small meals throughout the day is not really beneficial for these people that have all of these symptoms. And sometimes allowing those parts of intermittent fasting and, you know, having enough nutrition at a meal to, you know, keep you going, because some people do not eat what they really need to. You know, they need their fiber, their healthy fat, they need their protein, they need those type of things at every meal. And they need to be drinking their fluid. You know, I tell people half their weight in ounces. So, you know, 100-pound person needs 50 ounces. Can you hear that? Every darn time I do a podcast, they're cutting the lawn. I mean, really, I book these things at all different times. They must get into my computer and see this, and they say they're going to have a heyday on Cindy over here. Oh, Lord. So, you know, IBS. We hear about IBS all the time. Everybody's got IBS. And of course, we can break that down into a variety of different things. But when
25% of the population has IBS. So it's a big chunk of the population.
Right. And, you know, those people complain a lot, and they're uncomfortable, and they have gas, and they have bloating, and they have things. I know people that actually have left their their jobs because they've been with a lot of people and they can't control the gas, and it's odoriferous, and they might have a lot of problems needing to get to the bathroom quickly, etc. Can we take this apart and kind of just give us a visualization of what is causing first, the bloating, then the gas, then the pain, and then we'll talk about the two types. Some people get the diarrhea component, sometimes people get the constipation component. So give us that breakdown.
And some people get both, it's
all
a
of
mixed
it.
bag in terms of what they get. Yeah, I mean, it's definitely very challenging to lead a normal life when you have a lot of digestive issues, because again, we're eating food 3 times a day. So if you have something that's irritating your system 3 times a day, it takes quite the toll. And I've had patients who wouldn't travel because they were worried about what would happen on the plane. Like, would I be stuck in the bathroom the whole time? I don't want to be that person. Or you're the person in the gym class that's like ripping it out, and you're like, oh God, I'm that person, and it happens. It happened to me yesterday in my gym class, and I was like, not to me, but it happened as
okay.
general vicinity.
I want it. Yeah, you made it sound like it was more like something that happened to you.
No, luckily not me that day. But it can make, you joking aside, it can make normal things that we love to do really cumbersome. And it makes people tiptoe around their lives. And, when you start planning your life around your bowel movements and your habits, that's really where it becomes a huge issue for a lot of people. So I think it's really an important piece. And where we see the bloating, like I said, when we look at the physiology, what happens is, when the bacteria is breaking down the food in excess, because really, in our small intestines, we have a very low amount of bacteria. It's not a total clean environment, but it's much lower. Whereas in the large intestines, we have, we talk about having trillions of bacteria, millions, we have a lot of bacteria. So when we get an overgrowth of bacteria in the small intestines, when that bacteria starts eating the food, and eating the fiber, especially bacteria loves fiber, it starts creating gas. And when that gas starts pressing on the insides of the lumen of the small intestines, that's where it triggers those pain fibers in our nervous system. And that's where the pain and the bloating comes in. And really, that's where we get a release of gas, and you're either farting it or you're belching it or burping. It's trying to get out some way or the other. And oftentimes patients feel relief temporarily when that happens. And then obviously we've got the diarrhea component. We have a constipation component in some patients who get both alternating, which, like I said, could be really frustrating. Other symptoms that people don't exactly pin could be like elevated liver enzymes without drinking tons of alcohol, or liver stress, carbohydrate sensitivity, where they really don't find that they can eat carbohydrates without having an issue, acid reflux, anemia. So obviously, since that's the area where we're breaking down our nutrition, if that's not appropriately done, we start missing those nutrients. And that's where we see the weight gain and the weight loss. A lot of patients struggling with weight loss really just aren't absorbing their nutrients. So their body is giving these signals of, I'm starving, and holding on for fat for deal of life. So we see that, and then we even see it affecting the brain. So we see depression, we see anxiety. So that's where we start getting this complex of symptoms that we need to start connecting the dots to see exactly what's the core cause of that.
Right. But let's talk about the core cause of that. How does that bad bacteria, it's good bacteria, it's normal bacteria, but how does it become excessive? What things trigger that overgrowth?
So a number of things can trigger the overgrowth. And I think there's probably things that we still don't know exactly, but what it really does boil down to, in summary, is gut inflammation. So when we have gut inflammation in different scenarios that propagate that, then we have a higher likelihood of these things being an issue and the bacterial overgrowth being an issue. And there's a series of other things that kind of chime in. There's certain conditions that affect the nervous system of the gut, which slows it down. For example, a really common one, hypothyroidism. The thyroid plays an immense role in your body's ability to move the bowels. So a lot of people with hyperthyroidism struggle with constipation. Well, if food's not moving regularly through the chain, then again, that little bit of bacteria that's in the small intestines has a field day, and then they create more bacteria, and that starts to become a bigger issue. So we're really looking at a lot of nervous system issues. We're looking at food poisoning is a big one. So a lot of people will develop SIBO after a really bad bout of food poisoning. A common bacteria is Campylobacter that people get affected by. And what's interesting is that the Campylobacter looks a lot like the nervous system of the gut. So that can actually spawn a bit of an autoimmune response where the immune system starts attacking the nervous system of the gut as it's trying to fight the Campylobacter and just gets kind of tossed out of balance again. So we see that. Antibiotic use, common proton pump inhibitors, which, used to suppress acid when someone has acid reflux to suppress that symptom.
Give some names of PPIs so people know if they're on it, because when we say that, they might not know which ones they are.
Yeah, so we're looking at things like Prilosec, which is omeprazole. So because a lot of times we'll see the generic names as well. So omeprazole is Prilosec, and we get a few others. So we've got the other ones like Zantac and some of the bigger ones, which is pantoprazole. So a lot of the ozols at the end, those end up being proton pump inhibitors and affecting the gut.
Right. Right. And once that happens and you lower the amount of hydrochloric acid you're producing, and you've gotten this because you've got really bad reflux, and this is probably, we talk about an opioid crisis. I almost think that we have a PPI crisis out there because, a lot of people have reflux, and it's because they're not playing by the rules. Okay. You've got things that are irritating you. You got to stop. And let things rebalance. But once you cut out, the production or lessen the production of hydrochloric acid, then you're not stimulating the pancreas for the enzymes, and you're not bringing down the food. Even when you stop your PPIs, does it ever go back? Or is this a long time, after you stop that you have suppression of the hydrochloric acid?
I'm an optimist, so I think anything can be retrained back into the body. I think our bodies are really powerful. I think it's just a matter of one's determination and diligence and actually doing the things that will get you there. So you always kind of weigh out your pros and cons in any situation, like what's worth the work. So for some people, the reflux is so annoying and debilitating. Other people are like, I don't really care. I take a medication and that's it. Really what it comes down to is how fast are our lives moving? Appropriate food hygiene. As I mentioned earlier, it really starts in your mouth, and most people don't chew more than a couple bites before they swallow a big bolus of food. Chewing, I learned from Dr. Steven Sandberg-Lewis, and, I would watch him in clinic, and he'd have lunch, and I'd just watch him slowly chewing his food. And he was my chewing idol, among other things. But I would just watch him chew so slowly, and he was so in the moment. But it really does start up here before it gets down there. The less you do up here, the more work the rest of your system has to do to get all the balls rolling. And so really it's a matter of the speed in which things happen and identifying the underlying inflammatory processes that are happening.
Right. We're always so much in a hurry, aren't we?
Yeah,
you're trying to shovel in food because you got to get to the next thing. And that is a problem. I mean, if you've ever eaten something fast and you feel it going down and you're like, oh my God, I can't even talk. Like, that bite is not chewed enough.
So I mean, when someone's working with proton pump inhibitors, they're oftentimes trying to suppress acid, but it's really common that people are actually very low in acid, which is what makes them develop that symptom in the first place, because the food just sits in your stomach. It doesn't get digested and move forward. And oftentimes if people have any issues with their low esophageal sphincter, which is the sphincter that keeps everything down, if that's at all relaxed or too loose, food very readily and easily goes up into the esophagus and causes that symptom of acid reflux. So part of my physical exam really is looking at the different little sphincters and saying like, okay, are these in check for you to actually digest properly? And that is a really, really profound, simple treatment. My grandmother used to have, she was in her 90s, and she would describe her heart pounding, and she felt like she was having a heart attack. And as we get older, we have lower levels of hydrochloric acid naturally. You know, our enzymes start to have a harder time breaking everything down. So she was having digestive issues. And what I did is I went in and I adjusted her lower esophageal sphincter, and she just took this big, deep breath, and she goes, oh, my heart's not pounding anymore. And I would get these phone calls, you know, frequently and be like, hey, Tal, can you come back and fix my stomach again? And it was so profound. But, you know, a lot of these people who have that issue actually have a difficulty taking a deep breath, or they feel like it's really shallow, or they'll get this like heart palpitation feeling, or this like gentle pounding. And that's really because the stomach is actually plugging the diaphragm, so it just can't expand and contract as naturally as it likes to. So that's where, again, we get into the nervous system, we get into the structural work that helps a lot of people. And so it's really looking at it from so many different elements and picking it apart.
So do many people know how to adjust a lower esophageal sphincter? Remember, I did gynecology. I kind of had other sphincters I was dealing with.
Yeah. Yeah, I don't know exactly. In our training, it was part of our training in naturopathic medicine in our GI portion of our training. I don't think a lot of people do. Some chiropractors do, and a lot of people have different methods of actually adjusting it. So it just depends. But yeah, it's really about finding a practitioner that has done it before and has seen it. But I've seen it to be quite profound. I actually have a funny story about it. When I was starting my practice, I had to find a tax guy. And I talked to the tax guy, and the tax guy was like, what do you do? And I was like, naturopathic medicine. He's like, what's that? And I was trying to explain it to him. And I was like, what symptoms? Like, do you have any health issues? He's like, I have reflux. And I was like, oh, you've got reflux? I'm like, okay. I was like, get on your table. And so I got him on the table, and I adjusted his stomach. And I get a phone call the next day, and I got 3 months free tax work because he said, you fixed me of something that I've been taking medication for the last 25 years. And that adjustment made all the difference for the reflux.
Okay.
So
all right.
It can be it's pretty profound stuff. It's cool. It's not that hard either.
All right.
Once you know what to do.
Okay. Well, I'm willing to learn, so you'll have to teach me.
I know, next conference.
That's right.
Conference.
Next conference. We'll have to lay across the conference table and check that out. You know, we talk about Lyme disease. We know that antibiotics cause an issue. We know that there's possibility of other causes for SIBO. And you taught me one of, you know, outside of food poisoning and the antibiotics changing the bacteria, etc. You mentioned to me parasites. How common are parasites?
I think they're far more common than our tests are letting on, which is unfortunate because I know a lot of people like to see the proof in the pudding and see it on a test. But you really have to look at symptoms when it comes to parasites in tandem with testing. I had one patient, I felt so confident she had a parasite, and we did 16 stool tests before I found anything, because obviously these parasites have a life cycle. They're built to thrive on their own. They're symbiotic in some ways. And especially when we're looking at our Lyme population, we have an even increased susceptibility because, you know, these parasites do have some symbiotic component where they hold on to heavy metals for us, or they do certain things, but at the same time, they cause a lot of damage along the way. So it's really about, again, bringing down the inflammation, treating the associated causes. But parasites, I think, are very, looking back at the cases that I think I didn't do as well on, now with the knowledge that I have, I think parasites are a big component, and I think mast cell activation is actually a really big component as well. And of course, the Lyme bugs and things like that. Because as I started treating more SIBO, I was getting more challenging cases and more like head scratchers. And that's what got me to dig deeper into these other potential causes beyond the ones that are more commonly addressed.
So we can't
parasites
really,
are a big one.
yeah, we can't really rely on that type of testing. But I believe there's better testing for finding out what type of SIBO, right? Because there's a couple of kinds. So can you tell us about what kinds and what testing that we should be doing on our peeps?
Yeah, so first off, if you do a stool test, I always look to see, is there a lot of healthy bacteria flourishing? Because sometimes when you look at certain patterns, you can actually start to think like, okay, maybe I should be looking at SIBO. Sometimes stool testing will have something called methanobacter, which is a bacteria that creates methane. And that I oftentimes have seen associated with methane dominant SIBO. And oftentimes with SIBO, the most common testing that we do is a breath test. And again, when I say that the small intestines is 20 feet long, if you did an endoscopy, you get the top part of it. If you do a colonoscopy, you may get the bottom part. But that leaves so much footage of potential black box that we don't know exactly what's going on. So right now what we use traditionally is the lactulose breath test most commonly. And that tests for hydrogen gas as well as methane gas. There's a third gas, hydrogen sulfide gas, but unfortunately right now there isn't a direct test to measure hydrogen sulfide gas. But again, if you look at stool testing and you see some of the sulfur producing bacteria, that might tip you off as well. And then when you look at a SIBO test, if you see a flat line or a very low jagged rhythm, then that might also tip you off to sulfide gas as well. Symptomatically, you'll see people really sensitive to sulfurous foods, so like broccoli, cruciferous vegetables, cabbage, things like that, may actually increase their bloating because it's tipping off that sulfur bacteria that really loves the sulfur.
So,
pieces.
yeah, so, the hydrogen component versus the methane component, is methane the one that you see more constipation with?
Yes, we see more constipation with methane, but sometimes we'll get a mixed type with methane as well, where you'll see both constipation and diarrhea. With the hydrogen, we're more commonly seeing diarrhea. So that's what we're looking at overall to get the different types. And with sulfur, you'll get a lot of constipation as well.
So
and sometimes gas.
Sometimes gas. It's funny because bloating, and I always describe that because bloating that kind of comes and resolves, especially resolves overnight, that's an intestinal issue versus you wake up all bloated, especially ladies, we think of pelvic issues. And, for all the ladies that listen, one of the problems in pelvic floor health is that constipation where you're chronically, bearing down and whatnot, and you can really lead to dysfunction of that pelvic floor that can lead to of a control of bladder issues. So, we really don't want to be constipated. That being said, okay, so what do? You get this test, you kind of know what's going on. How do you break this down? What do you start in terms of your treatment?
So in terms of treatment, we're looking at supporting all of the healthy parts that we just talked about so thoroughly. But we're trying to see, do we need to support hydrochloric acid? Do we need to support enzymes? Do we need to figure out, do you have a thyroid issue? Do we need to fix that? So we need to get to the underlying pieces. And it's always where I start, because the thing is with SIBO, one of the most frustrating things, and most practitioners are hitting their head against the wall about it, is that it comes back. So you can do the antimicrobial herbs, you can do the Xifaxan and the antibiotics, you can do all of that stuff. But if you're not addressing the components that got it going in the first place, then you're more likely going to get a case that ends up with it back in your office after a few weeks to a month. So for me, first line really is zeroing in on that inflammatory process and helping the digestive system break things down and giving as much support in that process as possible initially, and then going into, okay, let's do these other pieces and add in the antimicrobials that may help.
Right. And, working with a dietitian is probably
Hmm.
beneficial with this kind of
It can be.
an issue. Yeah.
Absolutely.
Yeah.
It can be, because there's a lot of diets that are supportive of SIBO, and it really is a matter of finding a diet that A, you can get behind and be able to do, and B, have the adequate instruction of how to do it. There's a really great SIBO specific diet by Alison Seebecker,
Hmm.
and she's got a really great, that's what I use when I treat patients specifically for SIBO. But like in my recent treating of patients, I've been focusing a little bit more on the mast cell activation piece, and bringing down that gut inflammation and looking at the other components is actually shown to be very beneficial in getting people's SIBO symptoms to come down. So again, I've taken a little bit of a different angle from it, but there are a lot of diets that can potentially help people depending on what their individual situation is.
Talk about mast cell activation with this as a component leading to SIBO,
Hmm.
because like you said, this has been a different avenue for you.
Yeah, I think honestly, it's not necessarily that the mast cell causes the SIBO, but I think there's a very strong overlap in the symptoms. And I think we're hearing more about mast cell. I think we're going to continue to, but one of the key components of mast cell is bloating that can be aggravated by fermented foods. Well, fermented foods with SIBO also doesn't really jive, because again, you're introducing bacteria into potentially the wrong spot and getting an overgrowth. So you get these overlaps where you get the bloating, you get the diarrhea. I think with mast cell, you see a lot of other symptoms. You might get skin manifestations like rashes or just itchiness without a rash. You'll get headaches, you'll get migraines. So again, that complex SIBO case may actually be a mast cell case. You'll get joint pains, you'll get runny nose after eating. So you'll get a lot of these allergic symptoms in addition to the bloating and the digestive upset and the reflux. Reflux is another really common one with mast cell. So you kind of get like this Venn diagram where these symptoms meet in the middle. So it is important, I think, to discern between the two, and you can definitely have both. But if there's an underlying inflammatory component from the mast cell, it will make treating the SIBO harder, because you're going to be combating a whole different inflammatory cascade.
Is there a way to test for mast cell activation? Huh?
Mm-hmm. Well, we've actually been doing a lot of in-office studies on it. I'll be presenting it in a poster presentation at ILADS, what we've been able to observe. But what I've seen for testing is what can be helpful is doing a provocative challenge of the histamine and tryptase marker in the blood, because histamine tryptase is a very transient marker, so it's only there for a hot second. So I'll have people go in with yogurt, strawberry, spinach smoothie with a bunch of kombucha, and they'll just drink that, and it might cause some symptoms. But if they do that directly for the blood test, they may actually see that elevation in the histamine and tryptase. Another marker that we found that's easy to get through LabCorp is an MMP9. We just wrote about it in the Townsend letter, so there's more reference to how we're using that. But the MMP9 has been helpful in giving us another element of understanding whether someone has mast cell. And what we usually do, because MMP9 can be elevated for so many different reasons, we'll have them do a low histamine diet, a strict low histamine diet, and then have them follow up with another MMP9 to see if that one factor drove down that inflammatory marker. So that gets in very superficially into the mast cell component, but that could be one way of teasing it out. Is having a patient do a breath test, do a stool test, and do some blood work to look at the mast cell component. And really, if you're seeing that allergic component, it's really important to make sure you're checking for the mast cell piece.
Right, right. And there are a lot of foods that are high in histamine that people don't really know about.
Yeah. Yep,
yeah.
Or leftovers are a big one.
Oh.
People will eat leftovers and they're like, I feel terrible when I eat leftovers, but I feel fine when it's fresh. And that sends people into an absolute tizzy, because they're like, I ate the same thing and but I feel worse the next day, but I ate the exact same thing I ate a day or two ago. And it could very well be the leftover effect. So again, it's really important to have a practitioner that can tease these pieces out for you and help you kind of get through the weeds with it. Because a lot of these things overlap quite a bit.
So what happens with leftovers? Is it, Tell me. I'm trying to think this through, and I'm kind of stumped a little bit. I know it's an issue, but I guess I never really asked, what is the issue?
So the issue comes down to, we have natural bacteria and yeast in food. It's natural. It doesn't hurt you. It's fine. What happens is when food sits, that bacteria and that yeast starts breaking down the protein, and what it starts breaking down into is histamines. And there's no way of your body breaking that histamine piece down. So if you are sensitive to histamine, that overwhelming histamine load in the leftovers will add to the histamine that's already in your body, and it just becomes too much for your system. And that's where we start getting the bloating, the inflammation, the reflux, the headaches, the migraines. You know, we get a lot of that stuff when we get the histamine component, because histamine is a very neuroexcitatory neurotransmitter. So it actually crosses the blood-brain barrier and can cause a lot of nervous system issues. So we'll see a lot of anxiety, depression. Blood sugar imbalance is another common one that we see with the histamine issues, where they just have to eat all the time to keep their energy up. So it has a lot of really systemic effects. But again, the leftovers, it's the elevated histamines, and you can't destroy it. You can't change it. Once they're created, it's in the food.
There's no way to remove that.
There's no way to remove it. What we oftentimes recommend is people cooking as soon as the food is as fresh as possible, and then packaging them in individual freezer containers, and then pulling it out of the freezer and reheating it. Because when you freeze it, it freezes that production of histamine. And that's a way of, you know, eating your leftovers, but not having it be so cumbersome as cooking every single day.
Right. You know, that's important, because, you know, when we talk about food prep, you know, we try to help people who are really busy, and we talk about making big batches and saving it for a few days later. You know, what you had at dinner, you're going to now have in a couple days for lunch and whatnot. But I guess it's more important, if you're making big batches, that you really need to consider freezing. Yeah.
If you have a histamine issue, you know, you really have to identify that, because you're really working hard with the diet when you have a histamine issue. It's not an easy diet by any means, but if it controls your symptoms while you're figuring out why your body's under that state of inflammation, it can be dramatic to the rest of your program as well. If you're addressing bacteria or Lyme or co-infections or mold or other things, it can make a really big difference. But mast cell activation syndrome and that histamine sensitivity has a number of triggers that can be a component, but you really got to get to the underlying causes to really make it go away. Because I don't think it's a sustainable way to eat, and it's not a sustainable way to live, but it is that symptomatic support while you're figuring out the other puzzle pieces.
Right.
And as is SIBO. SIBO is the same thing. SIBO is the exact same thing. Again, if you can control it with diet, you can control it with herbs, you can give all the supplemental support, but that really just buys you the time and the comfort to be able to go into those underlying pieces, whether that's nervous system related or surgical scars or whatever work needs to be done, pelvic floor, as you mentioned, whatever work needs to be done to get those underlying pieces straightened out. And there's certain conditions where it may be an uphill battle, like Parkinson's, another, you know, chronic condition that is very common with SIBO. Well, you know, you can do the best you can with that, but you might have to be supporting motility and giving some extra love in that department for a long-term process to really keep those symptoms managed.
One of the treatments is a prokinetic. Are there natural prokinetics?
Absolutely. One of my favorite ones is ginger. I've gotten a lot of really great results with ginger alone. And even when I do LDN, sometimes with your compounding pharmacy, you can have them do a ginger filler. I throw it in because I'm like, it's ginger. And sometimes the cellulose in capsules bothers people. So the ginger root's actually a really nice option. But there are natural, outside of other, LDN is definitely helpful, but there are actually a number of natural prokinetics that work really well. Ginger just happens to be my favorite one.
I just want everybody to know who doesn't know what LDN is. It's low dose naltrexone. Yeah, that's come to the forefront. We see a lot more about it and reasons to utilize it. You know, while you're talking and you're thinking, you know, tummies and whatnot, I remember, and it's very common, children have tummy problems. Do you find that this is a common issue with children as well?
hmm I think that's a little difficult for me to answer because most of my patient population is more so adults than children. But I think with the world we live in today and the stressors that we're up against, children are experiencing so many more ailments than they were experiencing when we were kids or our grandparents' ages. We're just seeing kids being sicker and sicker for multiple reasons. So yeah, they're having more tummy issues. Our food is definitely affected. I think when it comes down to kids, they're young, they're vital. I think they can bounce back faster because they don't have the layers of complexity that we do as we progress in our ages. But yeah, there's definitely more kids coming in. And at the end of the day, our kids are more complicated than they were 10 years ago when I was practicing. And we're just seeing a lot more complexity where I'm sure SIBO is a piece too. It's just harder to get a lactulose breath test on a child. So we're not getting as much diagnostics, I'm sure, in that area.
People often think when they're having digestive issues that it should be improved by taking a probiotic. What do you think about that?
Well, obviously in the case of both SIBO and mast cell activation, those both actually don't do well with probiotics. And that's actually a common question I ask my patients when they have digestive issues is how do you do with probiotics? Because so many people have tried them based off of what they read in the media or what's touted out for general wellness. There are certain probiotic strains that elevate histamine and produce histamine. And same thing with SIBO. If you're taking a probiotic and you're populating the small intestines with more bacteria, again, it's healthy bacteria, it's good for you, but if it's sitting in the wrong place, then again, it's causing that same digestive discomfort. And that's where patients will know. They're like, oh, I hate probiotics. They feel terrible on my stomach. And they oftentimes know that they don't sit well with them. And that's another clue to look at both of those pieces and question further in both directions to see if you can figure out the nuances of the two things.
Yeah, that's common because people think that's the end all be all, you know. To the forefront, there's been a lot more S. boulardii, which is the friendly yeast, or we've seen more about spore probiotics. Are both of those another kind of issue where if you're not tolerating,
Yeah, we use spore-based probiotics quite a bit. And oftentimes with the way that we're treating patients now, I don't have to go into a lot of the traditional SIBO protocols. I really just bring down the inflammation as much as possible, use the spore-based probiotics, give some additional supportive support. And it really, like, I find that we're pushing it with a feather a little bit more now, whereas before I was hitting it more with a hammer. So I actually find that, again, if you can get to the underlying causes, you can actually do a lot gentler approach and actually get a lot of symptom resolution.
How do you reduce the inflammation?
So we try and reduce inflammation with the pieces that we're able to in the environment first. So that really is diet is first and foremost for us to reduce inflammation. If a patient has been affected by mold or mycotoxins or things like that, we may do some detox on that front, which may help because those mycotoxins do actually affect the gut as well and the gut bacteria balance. So we'll do some detox there that may help bring down, but really we're looking at the environmental sources of inflammation and the dietary sources first. And then we come in with whatever additional support we need to do, whether that's anti-inflammatories or natural antihistamines or other antihistamines as well, just some over-the-counter antihistamines, just to bring that inflammation down, just so that opens the door so that we can come in and you start moving things around without fighting all the inflammation that's happening in the digestive system.
You know, a lot of people want it treated now. They want it over now. This is not a sprint, right? This is more of a marathon.
More cases are chronic cases than acute cases. You'll definitely get those simple cases where they do a little bit of Xifaxan or they do a little bit of herbs and they're like good to go. That's unfortunately with what we're seeing, at least in our practices, because we see more complex patients, it's a little bit more of a rarity. And it really does take time and diligence and effort. And the thing is you can always treat a patient if they want that accelerated treatment, you can do it and always just say, hey, if this doesn't seem to be working, we have to wrap back around to doing the step-by-step process And so if patients are comfortable with that, you know, you give it a go, and we do some trial and error and see what works and what doesn't.
Right. Patients have to be willing to use the tools that you gave them in that toolbox. They also need to commit to be really good about their diet. And that always is a problem, because people think that if they put something in their mouth, they'll get symptoms immediately. But it might take hours or a day or two till things are like, uh-oh. And then they're like, well, what did I have like 5 minutes ago? What caused this? It's not. And people have to be diligent with, and know their triggers as well.
And that takes time. It takes time. It takes trial and error. It takes observation. It really takes being in your body. Because the thing is you can have the best practitioner in the world, but if you're not in your body to be able to communicate what's happening, it makes it a much more difficult process. So yeah, it takes level of commitment on multiple levels, and it takes a lot of energy. It takes money. It takes time. It takes, you know, just putting your heart into it. And those are all very energetically, they take up a lot of energy for us. So you really have to know what you want. So when I get a patient who says, I'm going on vacation, I'm doing this, I got this to do, I got that to do, I'm like, let's just do some simple stuff that will benefit you, because it will be more challenging to move mountains when you've got so much going on. So sometimes I'm like, all right, go on these trips, then create like some bandwidth for you to be able to actually put your energy into this space, because otherwise, you know, you just don't get out what you were hoping for if you try and sprint for it like that.
This has been a great explanation. Have we missed anything?
I don't think so. I think we hit all the points. I have a little list, and I think we hit literally every single thing. Right.
Very informative, and I'm laughing only because you sent me your list, and usually I will find all the things I want to talk about, but you prepared me very well.
Good, I'm glad.
Yeah, it's been awesome. It's been very, very awesome. And I didn't break in the middle, but I do want to thank my sponsors out there, Hopkinton Pharmacy, Biobotanical Research, and Master Supplements, who have been diligent about helping me get all this to you. So if you have not already subscribed, please do. Go to my website, www.livingwithlyme.us. Subscribe to the podcast series. No spam. I don't sell your email. Please do it for me, and you'll get some free recipes too. Thalia, this has been fabulous, and we got to get together again soon. We've got to find another topic. You are so knowledgeable and easy to talk to, so I'm really thankful that you spent this hour with me.
Thank you. It's been a pleasure. And thank you so much for creating this platform for practitioners like us to be able to have these conversations, because these are conversations I have in my office every day. And, you know, I think it's really important that it's available and more people have access to it, because, you know, when we're dealing with things like this, it can be so overwhelming for patients. And I know that because I've gone through a lot of these puzzle pieces myself. And it's really nice when you start to find some tidbits of information that can give you some leads to get you on the right path and get you where you need to go. So thank you for creating this platform for people to be able to find this type of information.
I'm thrilled to do it, and it's a lot of fun, really, you know. For everybody that has been listening, this has been myself, Cindy Kennedy, and Dr. Thalia Farshchian, and we've talked all about SIBO. So next time we'll have another great topic. I hope you come back and listen real soon. Take care, everybody. Bye now.